Inflammatory bowel disease management. Q&A essential questions and answers for general surgery residents. Welcome to our podcast episode on the comprehensive management of inflammatory bowel disease. In this session, we will walk through essential questions and answers covering Crohn's disease, ulcerative colitis, surgical indications, operative techniques, complications, and much more. Pause the video when you hear the word answer to attempt answering the question. Let us begin. Basic concepts and diagnosis question. What are the key differences between Crohn's disease and ulcerative colitis? Answer. Crohn's disease is characterized by transmural inflammation, skip lesions, and can affect any part of the gastrointestinal tract from the mouth to the anus. Ulcerative colitis, on the other hand, is defined by mucosal inflammation, continuous disease limited to the colon. Question. What serologic markers help distinguish Crohn's disease from ulcerative colitis? Answer. Elevated anti-Saccharomyces cerevisiae antibody is more indicative of Crohn's disease, while elevated paranuclear anti-neutrophil cytoplasmic antibody is associated with ulcerative colitis. Question. What is the role of fecal calprotectin in inflammatory bowel disease? Answer. Fecal calprotectin is a non-invasive marker of intestinal inflammation. Levels above 50 micrograms per gram suggest active disease. Question. What imaging modality is preferred for small bowel Crohn's disease? Answer. Magnetic resonance enterography is preferred due to the absence of radiation. Computed tomography enterography is faster but involves radiation exposure. Question. What endoscopic findings suggest Crohn's disease versus ulcerative colitis? Answer. Crohn's disease typically shows cobblestoning, deep ulcers, and strictures. Ulcerative colitis demonstrates friability, pseudopolyps, and continuous erythema. Medical management question. What is meant by the step-up approach in inflammatory bowel disease therapy? Answer. The step-up approach involves starting with 5-aminosalicylates for ulcerative colitis or corticosteroids for Crohn's disease, escalating to immunomodulators such as azathioprine, and then to biologic therapies such as anti-tumor necrosis factor agents. Question. When are corticosteroids used in inflammatory bowel disease? Answer. Corticosteroids are used for acute disease flares. For example, prednisone at 40 mg per day. Long-term use is avoided due to significant side effects. Question. What is the role of 5-aminosalicylates in inflammatory bowel disease? Answer. 5-aminosalicylates are first-line therapy for mild to moderate ulcerative colitis, such as mesalamine. They are ineffective for Crohn's disease. Question. What biologic therapies are used for inflammatory bowel disease? Answer. Biologic therapies include anti-tumor necrosis factor agents such as infliximab and adalimumab, anti-integrin agents such as vedolizumab, and interleukin-12 and 23 inhibitors such as ustekinumab. Question. How is Clostridium difficile infection managed in inflammatory bowel disease? Answer. Oral vancomycin or fidaxomicin is recommended, while metronidazole is avoided due to high resistance rates. Surgical indications question. What are absolute indications for surgery in ulcerative colitis? Answer. Absolute surgical indications include toxic megacolon, defined as a colon diameter greater than 6 cm combined with systemic toxicity, refractory hemorrhage, perforation, and dysplasia or cancer. Question. When is surgery indicated for Crohn's disease? Answer. Surgery is indicated for strictures with obstruction, fistulas such as enterovesical or enterocutaneous, refractory abscesses, and perforation. Question. What is the risk of colorectal cancer in ulcerative colitis? Answer. The risk is 2% at 10 years and 8% at 20 years. Annual surveillance colonoscopy is recommended after 8 to 10 years of disease. Question. How is toxic megacolon managed? Answer. Management includes nilperos, intravenous corticosteroids, antibiotics such as ciprofloxacin and metronidazole, and surgery if there is no improvement within 48 to 72 hours. Question. What is the role of surgery in pediatric inflammatory bowel disease? Answer. Surgery is considered for growth failure, steroid dependence, or complications such as strictures and fistulas. Surgical techniques question. What is the gold standard surgery for ulcerative colitis? Answer. The gold standard is total proctocolectomy with ileal pouch anal anastomosis. Question. When is subtotal colectomy preferred? Answer. Subtotal colectomy is preferred in emergent cases such as toxic megacolon or refractory hemorrhage, or when the patient is malnourished, with staged ileal pouch anal anastomosis performed later. Question: what are the complications associated with ileal pouch anal anastomosis? Answer: complications include pouchitis in 50% of patients, anastomotic leak in 5 to 10%, and infertility due to pelvic adhesions. Question: how is stricturoplasty performed in Crohn's disease? Answer: stricturoplasty involves a longitudinal incision with transverse closure, preserving bowel length. It is contraindicated in the presence of sepsis or malignancy. Question: what is the role of laparoscopic surgery in inflammatory bowel disease? Answer: laparoscopic surgery is preferred for elective cases due to faster recovery and fewer adhesions, but conversion to open surgery may be necessary for complex fistulas or abscesses. Complications and postoperative care. Question: what is pouchitis and how is it treated? Answer: pouchitis is inflammation of the ileal pouch and is typically treated with ciprofloxacin, metronidazole, or probiotics such as VSL number 3. Question: what causes anastomotic leaks after ileal pouch anal anastomosis? Answer: causes include tension and ischemia at the anastomosis, steroid use, or undrained pelvic sepsis. Question: how is a perianal fistula managed in Crohn's disease? Answer: management includes Seton drainage and biologic therapy with anti-tumor necrosis factor agents. Fistulotomy is reserved for simple or low fistulas. Question: what is the risk of short bowel syndrome after Crohn's disease resections? Answer: short bowel syndrome risk increases if less than 200 centimeters of small bowel remains. Management may include total parenteral nutrition, the medication tetraglutide, or intestinal transplantation. Question: how is infertility managed after ileal pouch anal anastomosis? Answer: in vitro fertilization is preferred, as adhesions increase the risk of ectopic pregnancy. There should be a discussion regarding pouch vaginal fistula risk. Surgical techniques and decisions. Question: what is the enhanced recovery after surgery protocol in inflammatory bowel disease? Answer: enhanced recovery includes early feeding, multimodal analgesia, and early mobilization, which collectively reduce length of hospitalization by 2 to 3 days. Question: what is the role of primary sclerosing cholangitis in ulcerative colitis management? Answer: annual liver ultrasound or magnetic resonance cholangiopancreatography is recommended for cholangiocarcinoma screening, and ursodiol may slow disease progression. Question: what is the pouch failure rate after ileal pouch anal anastomosis? Answer: the pouch failure rate is 5 to 10% at 10 years, often due to chronic pouchitis, fistula, or dysfunction. Question: what is the recommended protocol for dysplasia surveillance in ulcerative colitis? Answer: chromondoscopy with biopsies every 1 to 3 years is advised after 8 to 10 years of disease. Question: what is the role of fecal microbiota transplantation in inflammatory bowel disease? Answer: fecal microbiota transplantation is currently limited to Clostridioides difficile infection and has no proven efficacy for disease remission. Question: what is the preferred pouch configuration, J pouch or S pouch? Answer: the J pouch is preferred due to easier construction and better function compared to the S pouch, which is rarely used. Question: how is an intraoperative pouch tested for leaks? Answer: the air leak test is performed by insufflation under saline, or a methylene blue enema may be used. Question: when is a diverting ileostomy indicated? Answer: indications include high-risk anastomosis, malnutrition, or immunosuppression. Question: hand-sewn versus stapled anastomosis, which is preferred? Answer: stapled anastomosis is faster and has fewer strictures, while hand-sewn anastomosis is preferred for ilioanal anastomosis. Question: what is the role of robotic surgery in inflammatory bowel disease? Answer: robotic surgery has equivalent outcomes to laparoscopy and may be advantageous in patients with a narrow pelvis. Postoperative complications. Question: how is pouchitis treated? Answer: first-line therapy is ciprofloxacin 500 mg twice daily for 14 days. Refractory cases may require vedolizumab or ustekinumab. Question: how is an anastomotic leak managed? Answer: management includes diverting ileostomy and percutaneous drainage. Salvage of the pouch is possible in 60% of cases. Question: what is the management for pouch vaginal fistula? Answer: an endorectal advancement flap has a 60% success rate, with pouch excision as an alternative. Question: how is a pouch stricture managed? Answer: endoscopic balloon dilation is successful in 85% of cases. It is advised not to perform more than 3 dilations per year. Question: how is cupitis treated? Answer: treatment involves topical mesalamine or steroid therapy. Refractory cases may require mucosectomy. Medical surgical integration. Question: how should biologic therapy be timed before surgery? Answer: anti-tumor necrosis factor therapy can be continued as it does not increase post-operative infections. Tofacitinib, however, should be withheld 1 week preoperatively. Question: when should anti-tumor necrosis factor levels be checked post-operatively? Answer: levels should be checked at 6 to 12 weeks, with a target of infliximab greater than 5 micrograms per milliliter to prevent Crohn's disease recurrence. Question: when is thiopurine S-methyltransferase testing required before starting thiopurines? Answer: thiopurine S-methyltransferase testing should be done to avoid azathioprine in deficient patients due to the risk of myelosuppression. Question: what is the protocol for venous thromboembolism prophylaxis? Answer: low molecular weight heparin is recommended for 4 weeks post-operatively, as inflammatory bowel disease patients have a 3-fold higher risk of venous thromboembolism. Question: how is post-operative infection prevented? Answer: preoperative oral antibiotics such as neomycin and metronidazole, along with intravenous cefoxitin for colorectal cases, are recommended. Crohn's disease-specific management. Question: how is an enterocutaneous fistula managed? Answer: management includes nilperos, total parenteral nutrition, octreotide, and biologic therapy, with 60% healing within 12 weeks. Question: how is perianal Crohn's disease assessed? Answer: examination under anesthesia and magnetic resonance imaging of the pelvis are performed, with 90% sensitivity for abscess or fistula complexity. Question: how are strictures managed? Answer: endoscopic balloon dilation is used for short, less than 5 cm, inflammatory strictures. Question: how is postoperative Crohn's disease recurrence prevented? Answer: anti-tumor necrosis factor therapy should be initiated within 4 weeks postoperatively, reducing recurrence by 80% compared to placebo. Question: how is a rectovaginal fistula repaired? Answer: repair options include a Marcius flap using labial fat pad or gracilis interposition, typically after optimization with biologic therapy. Nutrition and metabolic considerations. Question: how is short bowel syndrome managed? Answer: the medication tetraglutide reduces total parenteral nutrition requirements. Monitoring for biliary sludge is necessary. Question: how is vitamin B12 deficiency managed? Answer: intramuscular injections of 1000 micrograms monthly are recommended if the terminal ileum resection exceeds 20 centimeters. Question: when should a DEXA scan be performed? Answer: a baseline scan should be done at diagnosis if steroid use is anticipated for more than 3 months and repeated every 2 to 3 years. Question: how can gallstones be prevented after ileal resection? Answer: ursodeol is advised if the resection exceeds 30 centimeters or if the patient is dependent on total parenteral nutrition. Question: how is osteoporosis treated? Answer: zoledronate is indicated if the DEXA T-score is less than -2.5. All patients should receive calcium and vitamin D supplementation. Special scenarios. Question: how is pregnancy managed in inflammatory bowel disease? Answer: biologic therapies can be continued in the 2nd and 3rd trimester, but methotrexate should be avoided. Question: how is pyoderma gangrenosum treated? Answer: treatment includes high-dose corticosteroids, topical tacrolimus, and infliximab for refractory cases. Question: what is the role of hyperbaric oxygen therapy? Answer: hyperbaric oxygen is an adjunct for perineal Crohn's disease wounds, typically administered in 40 sessions at 2.4 atmospheres. Question: what are the options for pouch salvage surgery? Answer: options include redo-ileal pouch anal anastomosis or permanent ileostomy, with 50% success if there is no sepsis. Question: what is the status of stem cell therapy in Crohn's fistulas? Answer: stem cell therapy is investigational for refractory disease, using autologous mesenchymal cells. Oncology surveillance. Question: what is the risk of pouch neoplasia? Answer: the risk is 1 to 2% at 20 years. Annual pouchoscopy is recommended if there was prior dysplasia. Question: how is cholangiocarcinoma screened in primary sclerosing cholangitis? Answer: magnetic resonance cholangiopancreatography and CA19-9 testing every 6 months are advised. Question: How is dysplasia in flat mucosa managed? Answer. High-grade dysplasia warrants proctocolectomy. Low-grade, focal dysplasia may be managed endoscopically. Question. What is the surveillance protocol for Lynch syndrome with inflammatory bowel disease? Answer. Annual colonoscopy is recommended starting at age 25, or 2 to 5 years before the earliest family cancer. Key statistics. Question. What is the rate of postoperative Crohn's disease recurrence? Answer. The rate is 30% at 1 year and 60% at 5 years based on endoscopic findings. Smoking doubles this risk. Question. What are pouch survival rates? Answer. Survival rates are 90% at 5 years and 80% at 10 years. Question. What is the mortality rate for emergency colectomy? Answer. Mortality is 5 to 10% in the setting of toxic megacolon, compared to 1% when performed electively. Question. What is the healing rate for fistulas with anti-tumor necrosis factor therapy? Answer. Healing rates are 60% for perianal fistulas and 40% for enterocutaneous fistulas. Rare cases. Question. What is a cock pouch and when is it used? Answer. A cock pouch is a continent ileostomy used as an alternative after failed ileal pouch anal anastomosis. There is a 20% rate of nipple valve revision. Question. How are pouch sinuses managed? Answer. Management options include endoscopic vacuum therapy or surgical debridement. Question. How is pouch prolapse repaired? Answer. An abdominal approach is taken, with resection of the pouch if it is necrotic. Question. How is inflammatory bowel disease managed in individuals with human immunodeficiency virus? Answer. Optimization of antiretroviral therapy is required. Live vaccines, for example, rotavirus, are avoided. Question. How is pouch outlet obstruction managed? Answer. Management includes botulinum toxin injection or surgical revision. Question. What is the most common cause of reoperation in Crohn's disease? Answer. The most common cause is recurrent disease at the anastomosis, occurring in 70% of patients at 10 years. Thank you for joining us for this comprehensive overview on the management of inflammatory bowel disease. Stay tuned for more detailed episodes on each section. And remember, knowledge and consistency are key in achieving the best outcomes for your patients. It's the Everything Surgery Podcast. Dissect the extraordinary.